because of the sake of time, I might be a little bit quick. Try to keep up with me. Yeah. The burden of RA. We might think we are treating RA in better times, but if you go to the statistics, we are not really. A lot of my patients ask me, do we get a cure to the disease? And before that, I need to know if I can get the remission. First of all, this is my disclosure. And if we go to the remission statistics, they are still poor by the DAMBio, by the Rabbit, and the Bryce UK statistics. It doesn't really get more than 25–30% in most of these studies. And how they measure the remission, there are different ways in how to measure remission. And here there is the first unmet need in how we can universal the remission measurement and achieve it. So how we go by these different measures in achieving this remission? The main three parts of the functionality of RA is a pain, functional disability, and fatigue. And patients are different to physicians in how to, let me say, rate or measure these findings. In addition, there are a lot of other measures could be taken into account. So to know these differences, one of the surveys saying for the same cohort of patients, physicians reported many patients as a mild disease, while the same cohort patients report most of them as moderate disease. They take many issues into account as a disease. For example, we all face it, like rheumatoid disease come with a neck pain or back pain. I say, look, my rheumatoid flares. So they may add a lot to the disease itself when we don't take it into account. How do we meet together? That's another question. Let's understand the story of rheumatoid arthritis. When you get inflammation, most of the disability you get at early disease is with pain. However, after time, you will get some damage, and then the disability coming because of the damage. And that, again, would, let me say, taken into consideration when we assess the patient-reported outcome and what disease stage they are before we judge on their symptoms. So from the early 20s and then evolved by the FDA and EULAR, patient-reported outcomes become first necessary, second is important to be incorporated in clinical trials as one of the target of rather than just CRP, ACR, or tender joints. So there are a lot of PROs has been established over the years and all used now in any ongoing studies. But there is a difference between these measures and what do they mean. There are patient-reported outcomes and there are physician-reported outcomes. And how do we know what you use according to the previous graph could match what the patient feel? The common ones, RAPID-3, that has been incorporated in the ACR and so many studies and been popular compared to other patient-reported outcomes. But that doesn't correlate with the DAS28, which is something we do in the clinic a lot. The best correlation is with the clinical disease activity score or index. And should we use this one because the correlation is very high? The one thing we know on a clinical ground, swollen joint and tender joint correlate quite well between patients and physicians. So if you have just a quick look, what is clinical disease activity score is a tender and swollen joint taken into account and patient VAS and physician global assessment. That's very easy, practical, you can do it in the clinic easily. You can add with the simplified disease activity by adding the CRP, which is again 1 to 10, and you can do this calculation without a computer. Just on a piece of paper, yes, that's your score. It's very easy. While you know it does, you need the equation to calculate the DAS score. Plus, we have all the question mark on the validity of DAS, particularly if there are fibromyalgic symptoms. So, the main one used in clinical trial is ACR core set of PROs. And this is difficult to apply in the clinic because it's a very complete set of let me say, details covering pain, fatigue, disability, swollen and tender joints, ESR, CRP, and using HAG disability, not the usual HAG especially for disability, and so on. So is the ACR is a good measurement for us in clinical trials. This is just an example. When we use ACR, particularly ACR 20, and usually we get a very high figures in some studies, like Bari compared to adalimumab. However, in baricitinib studies, they also individually check the PROs separately. And this is a very important and very clever at the same time. Why? Because ACR, because of the whole set, when you have a 20% response, you don't know where is the improvement where. Is it in the function? Is it in the tender joint? Is it in the lab result? It's just too big to take it from where to measure the improvement. Well, if you have individual PROs, that can give you a specific area where the improvement is and how much improvement is. So one of the measures they use HAG-DI. I'm here to criticize the HAG-DI in a way. If you use HAG-DI early in the disease, most of the trials will tell you a very excellent result of it, while it is more meaningful in the later in the disease for regarding disability. So the research communities, they are thinking to change the significant change in the HAG-DI from 0.25 to 0.375 for early disease in particular, because all trials can give you a positive result. And that might not be very relevant because it is for disability, not for pain. The other one, RAPID-3. RAPID-3, again, is a questionnaire filled by the patient regarding their abilities. Is it a perfect? It's very popular, but it's not very perfect. Because in the Western society, people walk daily as a way of life. And one of the questions, for example, did you walk 3 kilometers last week? We have, if we apply this to Middle East, we are culturally, we don't walk 3 kilometers a week. So that will be rated as negative. However, it's nothing to do with the disease. So there are a lot of questions might not really reflect the disease status to the best what we need to know. We need to measure the remission. So this is the question I'm talking about, and you find a lot of questions might or might not relevant. And I remember Yasser Midani, he wanted to include the Muslims' prayers part of these functional. He included in HAC, but it could be included in many other ones. Right, so the difference here, this is the ACR data, cover all these aspects. If you have 20% improvement, we didn't know exactly where is this improvement coming from. Well, if you have DAS28, that's mainly for a clinical response. We use it in the clinic, all of us, because it has been standardized earlier. People used to worry about CDI, but CDI proved with time is more valid one and very easy one to apply compared to DAS28. And I'll show you that in a minute. So this is mainly about the clinical findings. This is mainly about patient feeling. So if you have the combination of these two, it's just good enough for you in a clinic setting to see where are you with the remission. So this is the correlation between DAS and RAPID-3. You're supposed to get the line this way, but you see most of the dose are on the RAPID-3. So RAPID-3 labeled disease as more severe compared to the DAS calculation. So this means we are clinicians get it wrong and the patients get it right. So how we get to a point in the middle between patients and doctor to agree that the disease is good or bad. So the correlation CDI compared to DAS28, if you take this line, is much more nearer deviated to the RAPID-3 shift compared to the DAS28. So by many researchers, clinical disease activity index is a more practical and more relevant to reflect the disease remission compared to DAS28. So fatigue is one of the main ones, has been included lately and being pushed by FDA and others to be included in the clinical trials, because fatigue, we do believe, is part of the disease, not only secondary. And this is just one slide. Dr. Imad will elaborate more on the clinical trials, but this is only to show that this has been measured in the recent JAK trials, fatigue as in a facet F. Facet F is one of the most popular and most relevant or validated score for fatigue. And it showed, showed significantly how much improvement in fatigue as well. So when we look and we don't look at the pain is better, but the patient is still on fatigue, patient is still on disability, we are not achieving much. We can give painkillers for that. We need to achieve all these parameters, including the fatigue, as well as other PROs, is to make sure we are really achieving or closely to achieve disease remission. They have one of the very nice way of putting PROs in a clinical trials is the baricitinib trials, because they tested, in addition to the ACR, the PROs individually. And this is one of the most brave or best I've seen in terms of pain. They took the worst pain, not the average pain. And that's quite significant and brave to show, because that's not easy sometimes to achieve. However, what they show or what they achieved in a clinical trial is quite significant. And in the third part, I am going to show you my own cases and how true is this I've seen with my patient. So it's quite significant as well, and we can differentiate from, let me say, all ACR improvement to individual parts improvement. Similarly, monic stiffness is in the RA build trial, and there is a significant improvement. Again, Dr. Imad will elaborate more on the clinical trial programs altogether. And this is RA build, another part of the study, again with Bari at 2 doses against a placebo, which is in the conventional demands inadequate response. So altogether, we are having a better comprehensive way, try to judge on how we achieve remission. We have to take it both comprehensively in ACR and both individually to look at every element and which element any certain drug might or might not achieve well. But that would take us back again to the RA as a burden. One of the burdens, not only PRO, but how we achieve that. We have a new recent advances. I don't know in how many countries JAK has been introduced, but JAK by itself is intracellular blocker that could block more than one cytokine at a time. Although the worry initially this could be more side effect, clinically it has proved it's not, plus it's doing a fantastic job. The cytokines that could play part in the rheumatoid, we know IL-6, TNF, and some other cytokines, let's say interferon as well. And JAK has proved to play good role in balancing this between a pro-inflammatory and anti-inflammatory to achieve an excellent response, as we are going to see in the clinical trials. And this is just a summary of one of the JAKs, which is baricitinib, has showed a very excellent efficacy in terms of RA. It is JAK1, JAK2 inhibitors, primarily JAK1, and less potent on other JAK3. And it's available on a single dose a day, relatively short half-life, and achieve plasma concentration rather quickly. All these features explain why it has achieved some clinical response so quickly, and it could benefit from the first one. I've seen that myself, and it has mainly renal clearance, so it's less a problem with the liver disease. So that's a quick overview to explain what other slides coming on.